We're pleased to welcome you to this evening's presentation on the subject of how physicians are or should be allowed to assist their dying patients, a question which is receiving a great deal of attention recently and will be addressed tonight by a pioneer in this field of inquiry. Before I introduce the platform party, I have an announcement. Any physicians wanting continuing education credit for attending this lecture, please pick up the evaluation forms and fill them out at the end of the presentation in the lobby. I thought after you graduated from college you didn't have to do that anymore, but I guess I'm wrong. I'd also like to thank our K-State Department of Intercollegiate Athletics, which has graciously provided us use of their VHS projector for tonight's presentation. Our thanks to Max Urich and Scott Eilert. The speech is jointly sponsored by 3 KSU lecture series. The Lou Douglas Lecture Series on Public Issues was founded in 1980 to honor the memory of Lou Douglas, a distinguished professor of political science at K-State. Lou Douglas's wife, Mary, is with us this evening. The Lou Douglas Lecture Series focuses on topics pertaining to human rights, social justice, world peace, and international development. My name is Phil Anderson, and I am a member of the committee, as is Linda Tiener, the director of UFM, a sponsor of the Lou Douglas Lecture Series. The Dorothy L. Thompson Civil Rights Lecture Series honors the memory of Dorothy Thompson, who was an associate university attorney at K-State until her death in 1992. Dorothy Thompson developed K-State's affirmative action policy and the Commission on the Status of Women. The co-chairs of the Dorothy Thompson Committee are Jane Roulette and Robert Luttrell. The University Distinguished Lecturers Committee helps bring prominent visiting researchers, scholars, and distinguished intellectuals to campus. Professor Michael Donnelly is the chair of that committee, and he will now introduce our speaker.
Thank you, Phil. Patrons and friends of the Lou Douglas and Dorothy Thompson Lecture Series, ladies and gentlemen. Surely no issue or speaker could be more appropriate to our charge, the University Distinguished Lecturers Committee, than this evening's subject and lecturer. As academic disciplines as diverse as anthropology, history, psychology, literature, and ethics teach us, the ways in which cultures and individuals contemplate, confront, and deal with death are as telling and central as the ways they order and rationalize life. Our society, worshiping youth and health and power and self-actualization, tries hard to ignore death, hiding it behind a technological screen in hospitals and IC units, taking the rituals associated with it out of the hands of the dying subject and his family and friends, and entrusting the responsibilities for the passage to professionals. Nevertheless, our very scientific and technological successes in conquering some diseases, in retarding or holding at bay for a time the processes of aging, in repairing increasingly drastic insults to the human organism, have often indeed forced upon us new and unwelcome faces of death and the modes of dying. How we individually and as a society accommodate this last human rite of passage not only tells a great deal about us, but has immense personal consequences that each of us, as the truism maintains, may inevitably have to deal with. Suffering and death that have a meaning, that in some way are affirmed by one's culture and one's peers as defining or demonstrating character or identity, are quite another matter from the kind of prolonged death without dignity or point that many fear as an increasingly common end of life today in modern scientific, technologically advanced societies. But in its inheritance of the Judeo-Christian tradition, our culture carries a huge weight of ethico-religious animus against self-slaughter. At the end of the second millennium of the Christian era, this cultural animus against an act legally defined as felo de se has been seconded with the additional motive afforded by the model of certain genocidal totalitarian regimes, the first tentative steps of whose death machines were programs legalizing and encouraging medical termination of the lives of incurables, and persons viewed as social liabilities. Few persons are as qualified to address this emotionally fraught, socially and ethically charged issue as our speaker tonight, whose experience and commitment have made him an expert witness and educator of the public on all the major networks, as well as a contributor to the Wall Street Journal and the New York Times. Timothy E. Quill holds the doctorate in medicine from the University of Rochester, where he is today professor of medicine and psychiatry and director of the University of Rochester program for Biopsychosocial studies. He is also associate chief of medicine at the Genesee Hospital and a member of the Genesee Hospital Palliative Care Team, Pain Team, and Ethics Forum. Perhaps informed by his undergraduate studies of psychology at Amherst College, he has distinguished himself throughout his career by his caring, intensely sympathetic involvement with his patients as whole persons. He has interested himself in the individual's quest for meaning and in the peace and health of minds and psyches as well as bodies. This combination of interests has declared itself in his approach to physician education and mentoring, as well as his research and publications. Some suggestive titles from among the more than 30 professional articles authored and co-authored by Dr. Quill hint at the range and depth of his concerns. Bad news, delivery, dialogue, and dilemmas. Non-abandonment, a central obligation for physicians. End-of-life care in the Netherlands and the United States, a comparison of values, justifications, and practices, which is currently in press. And can physician-assisted suicide be regulated effectively? Dr. Quill has also contributed frequent shorter articles and non-refereed pieces, including Risk-Taking by Physicians in Legally Gray Areas, From Hubris to Humility, a Resident's Lesson, and an editorial contributed to the New York Times September 29, 1996, entitled Dr. Kevorkian Runs Wild. Finally, he has written 2 noteworthy books for lay audiences, both of which are available out in the lobby and in the Union Bookstore. Death and Dignity, Making Choices and Taking Charge, Norton, 1993, and the alternately challenging, harrowing, and inspiring case histories and the lessons they point to recounted in A Midwife Through the Dying Process, Stories of Healing and Hard Choices at the End of Life, Johns Hopkins, 1996. Dr. Quill comes across in these writings as anything but an ideologue. Rather, he seems the cautious, empirical, humane, good physician whose own clinical and personal experiences and deep reflections on the ethics of the exegoge have driven him to his role as public advocate. In that role, he's been a party to 2 cases heard by the U.S. Supreme Court, one of which, Vacco versus Quill, actually bears his name toward the history books on this contentious and ethically murky issue, pressing with increasing urgency upon each and every one of us. It is better for us, it is appropriate to us as rational and feeling human beings that we should think these things through carefully before we face necessities of acting or of suffering to be decided uninformed, unprepared, under perhaps great physical and emotional duress. Dr. Quill brings to us a unique perspective on this forethinking, having stood as physician, advisor, advocate, and friend at the bedsides of the dying, and as expert witness and prudent advocate before the highest court in the land. Dr. Timothy E. Quill.
I want to thank Michael for a wonderful introduction and Phil Anderson for being a great host while I've been here so far. And I'm also honored to be part of this lectureship which combines 3 lectureships, in fact. The Dorothy L. Thompson lectureship on civil rights that's devoted to civil rights, and the Lou Douglas lecture on human rights and social justice, among other things. And as you think about what I'm going to talk about tonight, I want you to think about the values that we're talking about here and try to struggle with them. For me, this whole debate is not a debate about the rights of people, autonomy, individuals. It's a debate about what are our commitments to the people we love and care about, how far do they go, how far should they go. And I want you to struggle with that, as I have struggled with it. Any of you who have a simple view of this issue, you have a fixed position on one end or the other. If you leave today with a more complex view of what the issues really are, I will have done my job, and hopefully you'll have something to think about a little more deeply. I'm going to use some images and some written slides. This is part of the culture of doctoring. We use slides when we talk. Maybe you can turn on the first slide, please. These are some wonderful photographs by Imogene Cunningham of people alive and functioning and engaged with life into their 90s. And when we use medicine's potential to keep people alive and engaged with life, we are doing a wonderful thing. Next. Next slide, please. Can we hit the next slide? There we go. But as we all know, growing old isn't for sissies. Next slide. Next slide. And the same interventions in medicine that can bring people back from the edges of death to potential recovery and returning to a meaningful life can prolong the process of dying. And I will tell you, as a physician, it is a daunting prospect to have the same intervention capable of so much good and so much harm. And many times when you're getting started in these things, you don't really know which way it's going to go. Next slide, please. And some of the rituals that have taken over our culture around the end of life is no longer death in the bedside, death that you are familiar with. How many of you, as young adults or as older adults, have actually been at the bedside of a dying person, been with them? More often, death is in the hospital. And our death ritual is cardiopulmonary resuscitation, a highly technical intervention. Next slide, please. And some of the interventions that we use are extraordinarily simple. This is a picture of Christine Busalaki, and many of the tough cases have been of younger people who was being kept alive by a feeding tube. Her parents, after she was brain injured, hoped that she would get better for about 4 years and used every drop of medical ability to try to get her better. And then they accepted the fact that she wasn't going to get better, and they tried to address the tough question, what would she want us to do under this circumstance? Which is the question we should all be trying to do when a person can't speak for him or herself. And they decided that she wouldn't want to be kept alive in this way, and they then spent the next 4 years, count them, 4 years in the courts, trying to have the feeding tube stopped. A feeding tube so technically simple to put in, yet so profound in its consequences. Next slide, please. So if we're going to use this technology, we have to learn how to not use it. We have to learn how to stop using it when it isn't meeting our goals anymore, because it is so powerful and so capable of prolonging life and prolonging dying that it is a very challenging prospect to try to decide how to use it well and how to use it so that we can take advantage of it, but also so it doesn't dominate our thought both clinically and morally. Next slide, please. Now this is a picture of Elizabeth Kubler-Ross. Elizabeth Kubler-Ross is who we all want to have caring for us if we have to die. She was the first person in the United States to really talk about death and dying, get it on the subject matter for people in our culture, which has really been a death-denying culture. Next slide, please. And I'm going to show you some images of a different kind of death. These are some pictures from the Cochrane Gallery about death on hospice programs, which is a whole different approach to the dying process. Next slide, please. Again, some of the moments in hospice are extraordinarily social and personal. They are things that teach us a lot about what it means to be a human being. Next slide, please. Some of the moments are extraordinarily mundane. They may be playing cards or watching television. They may just be being together without a lot of explicit death talk. Next slide. Some of the moments are exquisitely personal. They are things that you would never want to have shortcutted because they really tell us a lot about the human condition and what it means to be alive and dying. Next slide, please. There are also extraordinarily technical, medical parts of this process. There's a lot of medications, interventions that aren't all that beautiful or pretty or elegant all the time. They're part of trying to control the symptoms involved in this process. Next slide, please. But when it works well and we are able to help people die peacefully with what it means to be a person intact for them as individuals, we are doing a wondrous task. Helping people die well is a legitimate part of what medicine is and should be, and we have to learn how to do that better. Next slide, please. And these are some of the values of hospice care, and I want to contrast them for you for a minute with the values of acute medical care, because this is very important. These values, I think, underlie the whole process and the whole discussion that we should have. In acute medical care, we often put the prolongation of life as our foremost objective, and we often ask people to endure considerable suffering in the interest of prolonging their life. Consider a trip to the intensive care unit with tubes coming out of every part of your body. Consider very aggressive chemotherapy. You would never ask anybody to endure that kind of suffering unless it was for a higher purpose, their eventual recovery and return to a meaningful life. In hospice care, we accept the fact that we can't prolong life as much as we would like, so we're going to put the relief of suffering as our highest priority. And we may even use measures to try to relieve that suffering that may indirectly shorten a person's life. This has very much liberated us to use very high doses of pain medicine if they're needed to relieve a dying person's pain, because you'd never let somebody die in pain that could be relieved. In acute medical care, we often teach our medical students to attend to the underlying disease at all times. In hospice care, we accept the fact we can't address the disease as well as we would like, so we're going to apply that same kind of intensity to the person. It means finding out who is this person, what do they still want to accomplish, what's important to them at this point in their lives. We're going to try to give people as much choice and control as we can in this process. They don't have the kinds of choices they would like. To a person, they would all choose to get better if that was within the repertoire of choices they had. But within their narrow world, we're going to try to give them the most choice possible. We're going to manage symptoms very aggressively, because if you have a lot of symptoms, it's hard to focus on the other work of dying, like saying goodbye to your family and achieving closure with the things that are still left open in your life. So we're going to treat symptoms aggressively so that people can be freed up to work on other things. But perhaps the most fundamental value of hospice care is what might be called non-abandonment. And what this is a commitment to work with the patient throughout the process, no matter where it goes. If it goes to places where hospice protocols and medical protocols tell you where to go, what to do, you're going to go there together. But if it takes the patient and family down a dark alley where nobody knows what to do and the landmarks aren't there, you're also going to go through that process together and try to help them find their way through it. It's a profound commitment. I believe it is the commitment that people want from their health care providers, and is a commitment that is often lacking now in the current health care environment for a variety of reasons. Next slide, please. Actually, if you can warm up the VCR, I have a little bit of tape that I'm going to show in just a minute. This is a picture of a woman named Cynthia. One of the ways that I've tried to contribute to this debate is by telling stories of real people who face real illness, because this whole debate is very easy to have at an abstract level, and yet when you talk about real experiences of real people, it creates a tension between the individual and what we are thinking about intellectually and as a society, and that tension is healthy. It's not that one is more important than the other, but they need to be both present in the discussion. This woman was a graduate student at the University of Rochester. She was in her mid-30s. She was studying in religion and psychology. She was a practicing Buddhist for many years, for whom human connection and consciousness, self-awareness, were really central to what she thought was important in life. She was working on a dissertation and developed some abdominal pain. And to make a long story short, she went over about 3 days' time between thinking she had a little stomach upset, stress from her working too much, to hoping that she had a lymphoma because it might be treatable, to dying of gastric cancer. Now, gastric cancer doesn't happen very often to 35-year-old people, particularly in this country, but it happened to her. And there's no treatment that works for gastric cancer. All the treatments that have been tried are unsuccessful. So what do we do when treatments are unsuccessful? We generally do hospice care or palliative care, which she was offered at that time, which she experienced as abandonment. She said, I'm an exceptional person, which she really was. I need to figure out a way to fight this, and this led to a desperate search for some way to fight this disease that she was stricken with. She became my patient at this time, and we started exploring what options she had, and we came up with a possibility of experimental treatment, because at least that hadn't been shown not to work. It could work. On the other hand, it's very unlikely to work, and it's also very likely to mean that the last phase of her life is going to be spent in the hospital getting surgery and chemotherapy. So it's not a simple decision. But she was really interested in trying this treatment and in hopes that she would be the exception who would respond. Now, in order to get started on this treatment, she wanted a couple of reassurances. One was that she could stop if the going got to be too hard. That's an easy one, right? People can stop any treatment they want to, even if they will die with certainty as a result of that, as long as they know what they're giving up. And the second thing she wanted was some reassurance that if her dying got very harsh at the very end, that she wouldn't be left lingering, that she wouldn't be allowed to suffer in some extreme way. I will tell you that's a harder commitment to make in the current environment because we make some pretty sharp distinctions intellectually about what kind of ways we can help people. And I'd like to have you hear her talk about this for a moment.
Well, one of the things that was really healing for me on an emotional level and really helped me begin to decide that I was going to pursue some orthodox treatment, that I was going to pursue this surgery, was when both you and Dr. Caldwell were willing to talk with me about what might happen if you couldn't help me. You know, it was what I was saying earlier about Dr. Caldwell being willing to talk about what the dying process is like, and you were willing to talk with me about that. And the feeling that I got that no matter what happened, if this went, if I did recover or if I didn't, that you wouldn't abandon me, that I was more than just a disease, that I was more than just another case of gastric cancer coming through. And that helped me begin to open to all of the possibilities, both the possibilities of recovery and not. And because in my situation, I have to consider them all. All of them are possibilities at this point. And to have somebody that was willing to stay there with me through all of the possibilities, both the possibility of recovery, and that's where the hope comes in, and the possibility of not recovery, which means that you have to deal with the possibility, I'm thinking that you have failed maybe, or something, and get beyond that, you know, deal with that however you need to deal with that, and still be willing to stay with me more and that's different from saying we can provide palliative care. I don't know exactly how to explain that, but the feeling I got with that was that they would prescribe pain medication for me, but not that anybody would be willing to still have a relationship with me, a doctor-patient relationship with me, and sort of midwife me through the dying process, if that's what it came to.
Did you, as you've thought about this in probably a very personal way, did specific fears or issues come up about the dying process, things that for you were particularly important, if things went in that direction?
Yeah, I was worried about how painful it would be. I was worried about whether it would be a really long, drawn-out, agonizing process. I was worried about how helpless I would be and for how long, and how much of a burden, therefore, I would be on the people taking care of me. I was worried about whether mentally I would stay alert and able to deal with things, because if it does go, well, in any case, but especially if it goes in that direction, I have a lot of a lot of spiritual work I need to do to prepare to die, because I don't want to die frightened. I don't want to die resisting. I want to be ready, and I want to be at peace. And I know that if it were to happen right now, I wouldn't be. And so it was really important to me to know that sort of mentally and emotionally, I would still be there, still have those capacities, so that I could prepare, so that I could deal with this. One of the things I've come to realize over this last month is that
one of the things I would like to have you go home with is the concept of midwife through the dying process. It obviously has stuck with me because I think it captures what people are looking for in this kind of committed presence throughout the last phase of one's life. Armed with this reassurance, she was able to embark on very aggressive treatment. Her stomach was removed. She began very aggressive chemotherapy. And unfortunately, the disease continued to progress in spite of our best efforts. And there is nothing like a month in the hospital getting very, very aggressive therapy to make palliative care or hospice care look more promising. And she made a transition at that point to hospice care. She was dependent on a central line to keep food and fluids going because she couldn't eat now. She had no stomach. And her pain was well controlled on a morphine infusion. And she went home to get ready to die. And she had a wonderful month at home on hospice. She married her long-term boyfriend. The Buddhist community came to her house and meditated as a group and invited everybody to participate. And she gave away her favorite possessions so that people would have something to remember her by. It was a memorable experience, I think, for everybody who was lucky enough to participate in it. But after about a month on hospice, she was now ready to die. And her pain now was accelerating to the point that she required very high doses of pain medicine, which made her sedated. And she had intractable nausea and vomiting, excuse me, which is harder to control than pain is. And she had a very wide open wound in her abdomen that was foul smelling, that she found humiliating. And she was ready to die. And as we went and talked to her about this, it was clear that she was ready to die, and what we had to do was find a way to help her. And it turns out she has some choices. She's dependent on a central line for fluids and nutrition. She can choose to stop that, and she has pain, and she can choose to accept sedation that comes from higher doses of pain medicine, and that's what she chose to do. And she died quite peacefully over about 2 to 3 days. The difference between this case and the case that made me so well known in 1991 has to do with the method used at the very end of a very long process. And I would argue strongly to you that the method is the least important part of the process, that what is important is a commitment to work together and to make sure that assisted dying in any form is only done as a last resort when good care has been exhausted. And sometimes when people want to die, it's because we're not doing a good enough job delivering what's available palliative care. So no matter where you sit on this debate about whether we should help people to die at the very end, we need to work together to solve these problems. There's wide consensus about this, that we have limited access to care in this country in general, 40 million people uninsured, and we have limited access to hospice care for people at the end of life. You have to have the right insurance, you have to have a rather certain prognosis of 6 months or less. We need to make hospice care the standard of care for all dying patients and make sure they all have access to it. We don't train doctors as well in delivering end-of-life care as we do train them to deliver acute care. We'd never think about graduating a doctor who didn't know how to do cardiopulmonary resuscitation, but we routinely graduate them without knowing even the basics of pain management, how to relieve pain that might be treatable in a dying patient. We also have tremendous barriers in our culture about adequate pain management. This is both from the public as well as the profession. Still people worried about people who are dying becoming addicted to pain medicines and so forth. And these ought to be all surmountable. When we do offer hospice care to patients, we tend to offer it at what I consider to be 11:59. Persons at death's door, every conceivable technological option has been tried and failed, and there is nothing left to do, and we send them home for the last few days and give them high doses of pain medicine. Hospice, if we can talk about it as families and as medical providers much earlier, is really a much bigger process. It's about achieving closure to the end of your life, and you have to know you're in the end of your life in order to achieve closure in it. So we've got to learn to talk about the fact that a person is dying and learn how to not spend so much of their time in the hospital getting high technology care. We have reimbursement incentives that are getting turned all around in this country in medicine right now, but in general they still drive more and more technologic care and less pain relief and hospice care because it's not paid for as well. And we tend to not take suffering as seriously as we take the prolongation of life. Next slide, please. Next slide. There are also some limitations of palliative care or hospice care that are not correctable. And many of you may have seen hard deaths even on people who are on hospice programs. There are always a few cases on every hospice program where the kinds of symptoms people are having defy simple explanation, and we have to learn how to address those exceptions because that's a reality that our patients and our families are facing. Sometimes the exceptions are uncontrolled physical symptoms, like the case that I was telling you about, the pain that requires sedating doses of pain medicine to control in somebody who hates to be sedated, or nausea and vomiting, or open wounds, or the many other kinds of symptoms people might have. And then if we're going to talk about suffering, we're not just going to talk about physical symptoms, we've got to talk about existential and psychological and spiritual dimensions, and it would be preposterous to think that we have answers to all those dimensions of suffering. Yet that is, again, the reality that our patients are facing. Sometimes the kind of dependency, the kind of real caring in a bed, being totally dependent on others, is simply unacceptable to some people. Their independence is part of what makes them who they are. Now, for some people, they can adjust to that kind of dependency, but others can't. And finally, we allow some people to have choices and others not at the very end of life. And some of those choices can be made out in the open. Next slide, please. So we have a number of ways that we do help people to die. In fact, some people have estimated that about 2/3 of deaths in this country probably result in some way from some explicit decisions that doctors and patients and families make together. And some of these areas are completely agreed upon. For example, of kidney dialysis patients, people who don't have functioning kidneys who are on dialysis machines, somewhere in the range of 10 to 15% die because they choose to stop dialysis. Do they want to die? Not really. They just don't want to keep living under the circumstances that they find themselves. So they're making a choice toward death. James Michener, the famous novelist, was the most recent case that was publicized, who was a dialysis patient, finally found his suffering was high enough that he wanted to stop and was supported in that decision, could be made out in the open. Accelerating doses of opioids for pain, people finally deciding toward the end that they would rather be sedated than being in pain, and that is accepted, even though being sedated with pain medicine at the very, very high doses will hasten to death at the very end. The middle area, those in yellow, are areas that are being explored now as sort of new domains. One is called terminal sedation, where somebody who might be suffering in a severe way with symptoms other than pain can choose to be sedated to unconsciousness and then allowed to die. And people who argue about this believe that this is substantially different than other forms of physician-assisted death. The Supreme Court certainly said that this was okay, even in doses that would hasten death. Second area is voluntarily stopping eating and drinking. David Eddy, who is a physician's mother, was dying. She wasn't actually dying. She had a lot of illnesses, probably about 10 illnesses, but none of them imminently terminal. But she had had it because of her progressive debility. And she had access to medications because she had a son who was a doctor but didn't want to get him into trouble. And they came to the notion that what she could do was choose to stop eating and drinking and then allow herself to die of dehydration. It sounds a little strange at first, but in fact, many of my patients have read about this case and found it extremely helpful and liberating for them. Why? Because they can choose to do it, they can decide when enough is enough, and they don't need anybody's permission necessarily to choose that. And in fact, there seems to be a growing acceptance that this may be a possibility that people can have at the end of life. And finally, physician-assisted death or physician-assisted suicide is providing people with medication that they could take in an overdose at a time of their own choosing. Next slide, please. Now, we ought not to rush into this very easily or quickly. And I'm going to give you some of the arguments that oppose getting into this and some of the arguments that are in favor of getting into this. Clearly, if we are going to get into this, we are going beyond where people have gone in the past. We're violating our traditions, both our moral traditions and our professional traditions. And many very powerful and bright people are telling us this is a very bad idea. Next slide, please. We also know that healthcare reform is very active in this country. This is not a time where there's a great deal of trust in what's going on in medicine. Next slide, please. Next slide. So that people are worried about, will doctors hasten this along to save the Medicare dollar? Will we be coerced by our families so we don't spend the family fortune on our last days and lives? And you can clearly go through a tremendous amount of a fortune because medical care that's very aggressive at the end of life can be very expensive. Next slide, please. So here are some of the arguments, some of the risks of changing public policy. Most people, I think, can understand exceptional cases, the unusual case, the really tough case. But if you're going to change public policy, you have to worry about ordinary cases, ordinary patients and ordinary doctors. And are they going to be capable of the kind of really tough decision-making that we're talking about here? Of all the many slippery slopes that people worry about, the one that I worry the most about is the slippage from voluntary, a person making a decision for him or herself, to involuntary, us making a decision for someone who can no longer speak for him or herself because they seem to be suffering in an extreme way. Subtle coercion, might there become a duty to die, again, to save money for the family or to protect people from having to endure more suffering? We have the access problems that I mentioned earlier. And finally, people say doctors are powerful enough. Why give them more power than they already have? Now, what are the arguments on the other side? Next slide, please. First of all, people in the public are very, very interested in this, and public opinion polls, if you believe them, suggest that people are very supportive of the ideas of doctors being able to help them die more actively and more openly. Next slide. I'll read this slide. You probably can't see it. Medical ethics do not allow me to assist in your death. I am, however, permitted to keep you miserable for as long as possible. People sent me this slide. It's not a very funny slide, but from all over the country, people sent me this slide because there's a strong belief that we're not stepping up to the plate here, that we are allowing things to go on like the very early slides that I showed you in the interest of medical ethics, yet we're not really addressing the kind of suffering that's really going on. And if that isn't bad enough, we have a how-to book about suicide that was a bestseller in 1990. A very disturbing book that gave very practical information about suicide to anybody who might want it. A depressed adolescent can go to the library and get this kind of information. Or a mentally ill person can also get it this way. There's a chapter in here for older couples that's 3 pages long, big type, how we can do this together. If you want to see something like suicide be devalued and the complexity of these kind of decisions be devalued, you can read through this book. My sense is that people didn't read this book. They bought it and put it up on the shelf just in case they need the information in it at some date in the future. Next slide, please. This is my favorite slide. Those of you who have mixed feelings about Barbara Walters will like this slide. Well, this is, Georgiana says, this is one of Dr. Kevorkian's early failed cases. Kevorkian is a real wild card in all this. He's a very crazy guy in his own way. he is very interested in the moment of death. We're talking a little bit about this at dinner tonight, but not interested in caring for people who are dying necessarily. He's interested in helping them to die, but not caring for them. He doesn't have any skills that are involved in having a long-term relationship in terms of relieving symptoms and so on. You have to believe his 50th case was a hell of a lot easier than his first. There is nothing, I think, darker than the image of people going to Michigan to die at the hands of a pathologist in the back of a van in an alley. If that doesn't send a chill down your spine, there's something wrong with you. Yet when Dr. Kevorkian says, if doctors aren't going to deal with severe suffering that patients are having at the end of life, I will, I think he lays down the gauntlet, and he also strikes a chord that is very strong in the public, that we're not facing up to this issue and that we really have to think more creatively about it than we have. Next slide, please. We also know that many doctors do help a few patients in their career to die by providing them medicine that they can take in an overdose. Again, the case that I wrote about in 1991 that made me well known in this area, the only thing that was unusual about it, I think, is that I wrote about it. There's a secret practice. It's been well described, and even it's getting to be well studied. It's not that different from the practice in the Netherlands in terms of frequencies, in fact. Next slide, please. So what are the risks of current prohibitions? One is that we have a non-acknowledgement of suffering. We have people going through something and we're pretending like it's not there. And I think that's starting to change, which I think is a good thing, because if you've seen it, witnessed it in your own life, it is very scary to have people telling you it doesn't really exist. I think the exceptional cases that we do hear about reflect a much broader problem, and that we are allowed to help some people to die more actively than others, but it depends on the circumstances that they find themselves. We find ourselves in clinical medicine sometimes racking our brain for an indirect way to help somebody to die who is so desperate for an escape. So we have to find ways to fudge it or do it in a way that won't be seen as explicit, because you're not supposed to do this explicitly. We also have all kinds of cases of people taking matters in their own hands, violent suicides, botched suicides, by people who are just so desperate for an escape. The secret practice, I think, that we have now is much more open to abuse than a more open practice. I think I've become a safe person for doctors and families to call to get a second opinion. And I would say about 95% of the time when I provide a second opinion, I'm able to help people find a reason to keep going, a stone that hasn't been turned, that might not have been found if they didn't seek a second opinion. So I think the secret practice that's done underground with no second opinions is very troubling, because these are very hard decisions. With other very hard decisions like stopping life supports, we get our best minds together in medicine and make sure that we are only doing this as a last resort. Physicians hold all the power right now. Whether you get medicines or not, if you request this kind of assistance, depends on the values and the willingness to take risk of your doctor. And again, that's not necessarily where I want my future to be at the end of my life. And finally, we have the safest course from a legal point of view is to abandon patients who want this kind of assistance, to let them on their own, because you're not supposed to get involved in this, and that is clearly the most morally bankrupt. Next slide, please. Now, if you believe that public policy needs to change, what are some of the ways to change it? You can try to work with the legislature. I will tell you that legislatures in my state, and I bet your state isn't any different, have no taste for any kind of complex decision like this, right? They are not able to face up to it, and the federal government is no different. The polarized discussion, this is an issue that is too easy to get polarized. Referenda are the people talking. Referenda, really, you get something on the ballot box and then people vote on it, like in Oregon. It is democracy in action in a positive sense, but also the way you construct the referendum at the very beginning of this process is what you're stuck with at the end. So it's not allowed to evolve over time. So there are real problems with referendums. And thirdly, you can try a constitutional challenge, which we tried to change the U.S. Constitution. We're basically making two arguments. One would be a liberty argument, that people should have the right to be able to request this kind of assistance if they're terminally ill and suffering in an extreme way that can't be otherwise relieved, and that doctors should have a right to be able to respond. So it's not an absolute right, but it was a right to be able to request and doctors to have a right to be able to respond. The second argument that we made was an equal protection argument, which suggested that we are able to help some people explicitly to die, those who are on life supports, but somebody else whose suffering was the same or even greater but didn't have a life support to stop wouldn't be allowed the same kind of help. Next slide, please. And this was heard at the U.S. Supreme Court, and I'm going to give you a little snippets of the oral arguments at the Supreme Court. One of the things that was very impressive about the way the court dealt with this, in my opinion, was that it was a very serious discussion, very personal. There was not a lot of polarized discussion, not a lot of discussion that would make one think that they weren't addressing the real issues. Here's some of the things they said. O'Connor, this is an issue that every one of us faces. Ginsburg, this question raises the basic question about who decides. Souter, timing is a legitimate factor. Maybe the court should wait until it can know more. Stevens, I'm not aware of any doctor ever being convicted for committing this particular offense. Next slide, please. Kennedy, this is a question of ethics, morals, resources, and our commitment to treat the elderly and the infirm. Breyer, what worries me most is that 1% to 2% need die in pain, but 25% or more do die in pain. Rehnquist, you're going to have factions fighting it out in every session of the legislature. How far can we go in regulating this? And Scalia, why is it limited to those on the threshold of death? We are all terminal. Next slide. The Supreme Court decided that there was no right to physician-assisted suicide. From our point of view, we weren't arguing that there was a right to assisted suicide. That doesn't sound like a very compelling right. We were arguing that there should be exceptions for exceptional cases and people who were in exceptional circumstances. So they ruled very narrowly, and they sidestepped the issue that we thought was the core issue. But there were some strains in there that are very important. One was that there might be a right to a dignified death, in Justice Breyer's opinion, and a death that avoids pain and despair, in Justice O'Connor's opinion. And there was a lot of momentum within the court to consider very seriously those concepts, which really get more at the core issues, I believe. Next slide, please. There were some real positives. The court reaffirmed the right to refuse treatment, the right to adequate pain relief, even in doses that might hasten death. It affirmed the legality of terminal sedation, sedating people who are suffering in areas other than pain, even in doses that might hasten death. It did not devalue the discussion or provide overly easy solutions. Next slide, please. There is still no guidance about how to proceed, though, for the tough cases when good hospice care or palliative care fails. So it gave a status quo to the secretive process, which may or may not be a good thing. And there's still no legally predictable way of responding when palliative care fails. Next slide, please. There was an encouragement in the decision about debate and experimentation, a green light for state experimentation, either through the legislature or through referendum, the possibility of constitutional challenges in the future around particular cases, and a clear statement that the public discussion should continue. Next slide, please. So what's the big picture? Improving access to and delivery of palliative care or hospice care as the standard of care for people who are dying, and allowing for a more open and forthright process for those cases where good palliative care fails. We're trying to increase the choices for those who currently have very limited options. Next slide. I'm going to close by reading a letter that was written to me back in 1992 by a physician who had ALS, which is Lou Gehrig's disease. And this particular physician was quadriplegic, which means he couldn't move his arms or his legs. He couldn't speak, but he communicated through a computer using his tongue. And this is what he wrote. Who better than the individual patient to decide when the burdens that illness imposes on oneself, one's family, and society can no longer be justified by any possible contribution to the well-being of anyone? Transient extremes of depression are correctly resisted by all. Nonetheless, to the patient, there has to be an acceptable reason to carry on. Of course, I agree that the decision to seek death must be challenged by the medical profession and the family. But if no valid rationale can be offered for sustained existence, what then? Can the profession justify simply walking away from the problem? I think not. When my continued survival is no longer meaningful to me, I hope that a caring physician will make the transition as easy as possible. And I realize that some health professionals will find it impossible to do this, but I hope they and society will understand the true compassion for their patients' suffering that motivates the physicians who do help those in need. And I would hope that this understanding will lead to the elimination of unwarranted legal constraints when patient, family, and physician all concur. This particular physician continued to live for 4 years after writing this letter, and during that time continued to be a staunch advocate for what I think most people want in this whole debate, which is a loud voice in what happens to them at the end of their life. Thank you. We're going to have 15 or 20 minutes for questions if people have them. I'm told there are microphones on the side. Both sides. If you can find some, that'd be great, yeah. No. If there are those of you who have questions, you don't want to get up to the microphone, you can also just raise your hand or something and we'll try to get this started. Yes?
Field said something about trying to set up and establish a panel of physicians who would analyze each case, say, you know, whether you could go ahead with a physician-assisted suicide. Is that something that you would be looking towards in the future if this would ever become a common practice?
Yeah, the question is, Dr. Kevorkian suggested that there might at some point be a panel of physicians who might be able to make these decisions or review these decisions in a prospective way. I think the challenge in creating regulation is to allow people to maintain some privacy, right? Because this is a very private time in one's life, and you don't want to invite the whole world in to see you and have to evaluate you with some oversight. So people have talked a lot about regulation, but I think what is important about this is to have someone who has a lot of experience caring for people at the end of their life, who is an expert at palliative care and hospice care, knows how to relieve pain, to take a look at the situation and make sure that whatever criteria that you've agreed upon have been met. Now, if there are still tough cases beyond that, some cases where there's a disagreement, then I think such a panel, an ethics committee or something like that would probably be a wise idea. So I think some way to get it out of the closet, to have people document what they're doing and why they're doing it, I think would be a gigantic step in the right direction, and get real experts in to see these patients, in addition to the people who are intimately involved in the care themselves.
It wouldn't have to be specifically physicians, then you could have hospice people that would actually be the regulators?
Would it have to be physicians? People have asked whether any of this would have to be. Why not non-physicians? And I think there would be no problem if there were going to be a group of people taking a look at a decision. It would be important to have some of them be non-physicians. But there are very important clinical issues here, like assessing somebody for depression, assessing somebody for mental competence, making sure they're getting the state-of-the-art palliative care that are medical issues. So one of the people taking a look would need to be very well-trained medically.
I lived in Oregon at the time that the ballot went forward, physician-assisted suicide. was I was curious as to what was your first reaction when you heard that the voters decided that it was all right?
Those of you Oregon voters have now voted on this twice. They voted the first time in I think 1994, and they passed very narrowly, 51-49, a referendum that would legalize physician-assisted suicide, the provision of medications that somebody could take under very specified circumstances. And then it got tied up in the courts, and then the legislature got involved in Oregon and said that, well, people didn't really understand what they were voting on. That this was a determination, and they needed to re-vote on it. Well, Oregon voters tend to be pretty independent sorts, so I'm told, and they really don't like to be told what to do. So in the re-vote, this same legislation was passed by a 60% to 40% margin. So that doesn't necessarily mean, I don't think, that it is that the popularity has increased by that amount. I think it's a strong vote against government intervention where people don't want to have it. There have been some interesting things that have happened in Oregon, though, since the referendum has been really seriously talked about. Number one is when you have training sessions around pain management or how to talk to patients about dying. Everywhere else in the country, they are attended by nurses and social workers and others. In Oregon, they're attended by physicians. Because all of a sudden they are taking, if we're going to listen to people, we're going to have to learn how to do this. Well, Oregon has gone from 10th or 15th in the nation on the prescribing practices of morphine at the end of life to number 1. If these are the effects that passing this legislation is going to have, we should all pass it right away. I don't know whether that's going to be a lasting effect or not. I do think it is useful to have the experiment, if we're going to experiment with this, occur on a smaller basis, state by state. I think you could make an argument, since we don't know whether the good outweighs the bad of legalizing this, carrying out on a state-by-state basis may have some value. Yeah?
Do most national hospitals nowadays have an ethics committee that decide what you're talking about?
Most hospitals have an ethics committee. They are very variable in terms of the skill level, in terms of the training that people have who are part of that committee, but they are bodies that try to deal with the tough clinical questions. This particular clinical question, though, would be, I think, out of the realm of ethics committees. They could talk about stopping a life support on a patient, but if they were talking about providing a patient with medication to take in an overdose, because of the legal implications of that, they probably couldn't render a decision about such a decision. So legal is very different from ethical, right? Ethical is sort of right and wrong, and legal is what does the law say that you can and can't do. This is a legally very difficult issue in the current environment. Even though no one has ever been successfully prosecuted for participating in this. I was told, as I was writing this article that I wrote in 1991, sort of chronicling the case that I took care of, I was told just this: no one's ever been successfully prosecuted, besides what you did, probably technically, according to the law, it doesn't count as physician-assisted suicide. But what I wasn't told was that you can go through one hell of a process on your way to not being successfully prosecuted. And so, you know, it's in the media, and people are looking at this. But I also don't think they are prosecutable cases. I think if you can't prosecute Kevorkian, you can't prosecute anybody. But also, your license is in jeopardy. I think, depending on the local climate, you could really be in some danger by openly admitting this. People don't mind you doing it as long as you don't talk about it.
Yeah, I kind of had a question related to the licenses. I think the biggest argument that I've heard against physician-assisted suicide is that it's not the position of a doctor or physician today to facilitate death. That's not their role. It's fine if they're suffering and they want to die, but it's not the doctor's role. And I was curious, is there any kind of curriculum in medical schools or anything else for students who want to specialize in facilitating death?
There are many people who make that. It's not the role of the doctor to help somebody to die. It's sort of how the doctors aren't about death. Well, in fact, we are about death. If you look at who's in the hospital now, in most of our hospitals, people who are likely to recover are generally not in the hospital. It's an overstatement, but a lot of people are dying in the hospital. So we better learn how to take care of people who are dying and learn how to think about that more clearly. Now, that does not necessarily mean causing their death, but it does mean relieving pain, relieving symptoms, learning to talk to them about what their goals are, their values are, which actually is the process of caring for somebody who is dying. And there is a lot more in medical school and medical residency curriculums now that are moving that direction. For example, at our residency program, every intern now spends a month on a hospice program. They take care of nothing but dying patients. They learn that dying patients have something to say. They learn that they have goals and things they want to achieve. They learn that they have fears. And they learn that they really need somebody who's committed to not let them suffer. And that's a role of the physician. Those are the kinds of things we have to teach people to learn. I think that those who are specializing in this area are going in the direction of becoming hospice physicians or palliative care physicians. And they're learning how to talk with people about dying and learning how to help them in one way or another. Physician-assisted suicide is just one little way, one little part of a much broader process of learning how to help people not use treatments they don't want, learning how to stop them when they don't want, when they're no longer serving their goals, and so on. Yeah.
You mentioned several times the issue of the legislature here, legislative branches being slow and resistant to wanting to move on this sort of issue.
Right.
What would then be the issue for the Supreme Court or the Supreme Courts of the land to try to expedite this process or speed it up? What would your opinion be there on how they could aid that process? I know you mentioned two Supreme Court judges that seem to have some understanding and, well, not understanding, but some lean towards your own positions on some of these issues.
I think some of the messages that the Supreme Court gave to our legislatures is that if they create laws that are really prohibitive from good care, for example, if they really made it very risky to give high-dose pain medicine at the end, that those kinds of cases they would take a look at, and I think they would give a very clear message that that's simply unacceptable. I think we can ask our legislatures to do away with the things they're doing that are really getting in the way. In New York State, for example, we have triplicate prescribing laws for strong pain medicines for opioids. So you have to prescribe them in a special form. It's very heavily regulated. There's wide consensus that this gets in the way of good pain management. In New York State, we have some case law that suggests that you have to have clear and convincing evidence of a person's wishes to withhold any kind of life-sustaining therapy, including a feeding tube. It flies in the face of any kind of common sense to do this. And those are the kinds of things we may get or may not get legislatures to deal with. But I don't think it'll be around the area of physician-assisted death because I think it's too much for them to handle.
But do you think the Supreme Court should step up to try to expedite that process, to try to speed up the addressment of this issue?
I actually think what they did was just right for right now. I think they really did affirm many things that there's consensus about. They pushed the envelope a little further. I think they suggested that if things aren't moving enough, they will take another look at it in another few years. I think we have to move the middle ground forward, which is moving very rapidly. You know, the AMA, the American Medical Association, for the first time in its history has taken on good care of the dying as one of its central initiatives. 1996, for the first time. Hugely positive. You know, the most conservative, it's like the doctors, what would you call it, lobby, or the doctors, kind of club. So they're taking on good care of the dying, and so that is a very, very powerful thing to do. So I think there's a lot of good movement to the middle ground. If that lags behind, I think we'll see another case go up to the Supreme Court.
Yes, sir. During your presentation, you made reference to the power of the physician, and then to the concern for the slippage from voluntary to involuntary.
Yeah.
What kind of safeguards do you see or foresee being implemented to make sure that as this progresses, that it in fact does not slip?
Yeah, the safeguards, probably the most important safeguard, in my opinion, is, first of all, getting the process from under the table to out in the open. Secondly, the second opinion by somebody who is skilled about this, and then a review of all decisions that are made based on this data. So that it is possible to think about forms of regulation that wouldn't be too intrusive, that would really help. You know, when you think about all the slippery slopes, you look at the exact same arguments were made against allowing people ever to stop a life support. You know, 10 or 15 years, the exact same arguments were made. Because wouldn't it be coercive? Won't people be forced to stop life supports against their will? Won't they be? And in fact, it's done very conservatively now, even in the current environment. And we get second opinions, and the documentation is meticulous when we generally do this. So I think that's the model in my mind. Now, I have faith that this is hard to do. Okay, if it became real easy to do, I would worry a lot about that. But it's inherently hard to do. And if you get people documenting what they're doing and justifying it according to whatever criteria that you set up, I think those are pretty good safeguards. They won't be perfect. But right now, with a secretive process, I shudder to think about some of the decisions that are made in secret that nobody's talking about. I think that, from my point of view, that's probably more dangerous. Although that could be debated, we don't know. Yeah.
How does the advance medical directive fit into this picture?
Well, the advance directive, just for those of you who don't know what an advance directive is, there are two kinds of advance directives. One is a living will, and the other is a healthcare proxy. A living will, how many of you students have a living will, by the way, or a healthcare proxy? Yeah, a few? Okay. The most famous right-to-die cases, again, are of people about your age who lost the ability to speak for themselves. And that's when these documents take over. They take over if you can no longer speak for yourself, and medical decisions have to be made. A living will sets out what your philosophy is about these kinds of decisions, and a healthcare proxy says, if I can't speak for myself, I want you to speak to my wife, mate, mother, father, child, or whatever, who knows me the best, who knows my values the best. These documents now, I think, have widespread acceptance, at least in theory, and I think they are being followed more and more, but still only about 20% of the population have them. So they're very important. I would encourage you all to fill them out because otherwise, if you don't fill them out, what happens? People, what's the default position? Default position is every drop, you're presumed to consent to every drop of technological intervention. If that's what you want, you're fine. But if you wouldn't want that, if you were kept alive in a severely brain-damaged state, would you want to be kept going indefinitely? If you wouldn't want that, then you need to think about one of these documents, because that's the default position. And unfortunately, this default position goes whether you are 20 years old or 90 years old. So we have 90-year-old people who simply have never said that they didn't want these things, who are presumed to consent and therefore getting them. And most people say, gee, I really wouldn't want them. It defies common sense. Some people would want them, and they should also fill out an advance directive saying, I would want that kind of intervention. One or two. Go ahead.
Thank you. In today's profit-driven healthcare market, what are the real risks of HMOs or families, as you said, sort of subtly asking people to die, or the option of people who simply can't afford health care to just die instead of even being able to be given the chance of treatment?
Right. No, these are very real risks that are in our environment right now. Now, they are in our environment right now anyway. And we are making decisions like this anyway, right? About, for example, whether to do dialysis, whether to stop dialysis. These decisions are occurring all over the place. So what protects people, I think, is to have these decisions occur out in the open, explicit rather than underground. We have rationing in this country. It's just not explicit, right? We just don't offer 40 million people health care. It's not that they don't want it. It's not that we don't have an obligation, morally or otherwise. We just don't offer it to them. So we need to get that all out of the closet and out in the open, I think, and that's the best way to protect people. Now, managed care is not all a bad, right? Because you can look at managed care and you can have these big systems that are being created. Think about, how do we want to care for people who are dying? We can require that they have systems of care that are devoted to their patients who are dying. In fact, they can be competing around this. In fact, in Oregon, the managed care organizations are now competing to see who can give better care to the dying. Well, again, if that's what can happen when you open this up, that's a very good thing. On the other hand, the risk is that you could create real financial incentives to have people choose death prematurely, and that would be a very bad thing. So how do we protect people? I think by getting it out in the open and having an open discussion, documentation, particularly if you're doing anything that involves hastening death, be it stopping a life support or anything else. Last question.
Yes, I appreciated your talk. I'm a physician, and you made a comment at one point in your talk that we need to help people die well and we need to get better at that, and I would agree with that statement. I did not receive really any training in end-of-life care, and I think I'm better than I was when I first started 6 years ago, but I still have a lot of room for improvement.